pregnancy and also to medicinally with their kids as they were growing up. The kids had a higher level of learning and higher sociability. So it's interesting to look at that research too.
Yeah. You could say that was because the mothers tended to self-pump. And so there was more of a social stimulation at their houses, they had more income.
Yep.
So they didn't attribute the increased benefits to the pot, but to the social.
Absolutely, and the social factors, that was part of that study. It wasn't just the selling of cannabis. Those women who were able to afford cannabis tended to be from more affluent communities than those who didn't. And so there was an interesting tie in there, but good research to at least support no dangers or no particular harms. So for our next collaboration, I teamed with Dr. Andy Hathaway at the University of Guelph to design a research protocol to poll end users of our federal medical cannabis program, something that Health Canada, by the way, has never bothered to do. We launched the study in the spring of 2007. It's called the Quality of Service Assessment of Health Canada's Medical Cannabis Program, and it combines a 50-question survey addressing the personal experiences of patients in the federal program with 25 semi-guided interviews, and it's funded by the McMaster University's Arts Research Council. In total, we received over 100 responses to the survey, and these results reveal the scope and nature of ongoing patient concerns with Health Canada's program. Here's a brief summary of our findings, the rest of which will be published in 2010. Over 90% of patients report not all strains are equally effective at relieving their symptoms. Now that's important because Health Canada only supplies a single strain. 97% state a preference for purchasing cannabis from a source that offers multiple strains. So once again, Health Canada simply not listing a patient experience here. 90% preferring to have access to multiple methods of ingestion, such as baked goods, tinctures, oils, and hashish. And those are things and products typically just found at community-based dispensaries. 68% report cultivating their own cannabis. 48% have tried the single strain of cannabis distributed by Health Canada. And 75% of those who tried the Health Canada cannabis ranked it as either a 1 or a 2 on a scale of 1 to 10, with 1 being very poor and 10 being excellent. So in light of these results, it's perhaps unsurprising to learn that 72% of patients stated they were somewhat or totally unsatisfied with the federal program.
Did anyone answer excellent?
No one answered excellent, except for their own cannabis. We asked the same thing. We asked the patients to rank their own cannabis, and they ranked it between 8 and 10 generally, whether they were getting it off the black market, growing it for themselves, or through dispensaries. For our next major community-university partnership, here we go. Additionally, in 2008, I undertook the first comprehensive policy overview of Health Canada's medical cannabis policy and practice, which concluded that despite spending over $30 million to date on this federal program, there's a growing body of evidence that it's not meeting the needs of Canada's medical cannabis patient community, and that it actually may be acting as an impediment to safe and timely access. The study makes several recommendations to improve medical cannabis access in Canada, including the need for a federal audit and review of the government's medical cannabis policy and practice, for cost coverage of medical cannabis by federal and or provincial healthcare programs, since cost has proven to be a major impediment to access for many medical users, and for the development of a cooperative relationship between Health Canada and compassion clubs to both improve patient access and to jumpstart research into the safety and therapeutic potential of medical marijuana. In 2009, I furthered this research with the publication of a sociological examination of medical cannabis in Canada titled Moral Regulation, the Presumption of Guilt in Canada's Medical Cannabis Policy and Practice in the International Journal of Drug Policy. Citing Australian researcher Alex Woodach, who I understand is going to be speaking today over Skype or something, I know he's on the schedule. Citing Alex Woodach's work on the ethics of drug policy, this study concludes that the viability of the federal program will depend on the government's ability to shift away from deontological approaches based on oppression and moral regulation and towards consequentialist policies focused on benefit maximization for medical cannabis patients, which is a term coined by my friend and fellow panelist Ken Tupper in publications addressing ayahuasca-based therapies, and you can hear more about that, I'm sure, later. Although the lack of federal support for medical cannabis remains a challenge, published data reflecting the experience of thousands of medical users has already highlighted many new indications for cannabis-based therapies, and including its potential to treat addiction by reducing problematic use of other listed and illicit substances such as alcohol, opiates, and stimulants. In a project supported by the University of Victoria and the Centre for Addictions Research of British Columbia, I'm currently examining substitution theory and the potential of cannabis to be used in the treatment of problematic substance use and addiction. Now, this area of research could radically shift the popular perception of cannabis as a gateway drug, leading to the use of more addictive substances, to that of an exit drug, helping people control or even end their addiction to potentially more dangerous substances, including alcohol and tobacco. The immeasurable social harm and hypocrisy of the international war on drugs are perhaps best exemplified in the ongoing persecution of patients who benefit from the use of medical cannabis. The development of community university research partnerships with compassion clubs is a remarkable act of resistance to the prohibitionist ideology that dominates our federal approach to substance use and has proven incredibly successful at giving voice to the lived experiences of this marginalized community of critically and chronically ill Canadians. By engaging and empowering patients through joint knowledge creation, medical cannabis dispensaries and university-based researchers, like many of the people in this room, continue to challenge the government's failed federal policies, shifting Canada's medical cannabis program away from policies driven by fear, ignorance, and prejudice, and towards patient-centered practices based on science, reason, and compassion. So my thanks to CSSDP for putting on this fascinating conference, and to all of you for your time and attention. I look forward to your questions. Thank you very much.